Uh, it's my pleasure to introduce my friend, Professor Mohmmed Alkebsy, in the next lecture, the management of cardiovascular disease in diabetic patients. تفضل دكتور.
Assalamu alaikum jami'an wa thank you very much Chairman for your introduction. شكرا للدكتور زايد for his invitation. طبعا يقولوا ما حدش يبيع المية في حارة السقايين. فأنا اليوم يعني ضيف عليكم وأتمنى أن تخفوا علي خصوصا الاندوكرينولوجيست. This is my title. I have no conflict of interest, and this is my agenda. We will go through the cardiovascular risk assessment. Then we will discuss lipid management, blood pressure management, and antithrombotic in diabetic patient, also lifestyle. Then we will go to the summary. So you can see how many guidelines raised at least in the second 2 years. كده كويس؟ Okay. Many guidelines was issued in the last 2 years, and I will try to take some hint from these guidelines. طبعا we all know this level of evidence and recommendation. Class 1 means you should do it. Class 2A, you can do it. Class 2B, you may do it. And class 3, better not to do it, or maybe it's harmful. So this is the aspect of cardiovascular disease in the diabetic patient. We start to have the presentation of patient coming with diabetes. And after the presentation, we can go to the diagnosis and the evaluation. After the diagnosis and the evaluation, we go to the treatment. And the guidelines is very clear that in cardiac patient or patient with increased risk of cardiovascular disease should be screened for diabetes, including fasting blood sugar or HbA1c, plus minus HbA1c. Vice versa, if the patient has diabetes, should be screened for blood pressure, heart failure, and chronic kidney disease. We will start with the assessment or a risk assessment for cardiovascular disease with in patient with diabetes. And actually, there is a new scoring system. We used to have the score 2 system, which was issued by the European guidelines. But now they start to add what we call it score 2 diabetes. And they added age of diabetes as a criteria, HbA1c, and estimated GFR. And okay, this is a slide, but I'm sure that you cannot do this risk assessment by this way, but you can take the code and you can download the apps in your mobile, and then you can do risk assessment easily. So when we do risk assessment in diabetic patient, make it easy. If the patient has diabetes and he has already atherosclerotic cardiovascular disease, that means no need to do risk assessment or score 2 diabetes in this patient. The second one that you don't need to do the score diabetes is patient who has target organ damage. What we mean by target organ damage, estimated GFR high, microalbuminuria, proteinuria, or at least microvascular disease in 3 organs such as albuminuria, retinopathy, or neuropathy. But if the patient is diabetic but without atherosclerotic cardiovascular disease, in this situation you have to do score 2 diabetes scoring. And according to the score 2 diabetes, they classify the patient into very high risk and high risk and moderate risk moderate risk, and low risk. What we mean by this is the 10 years survival in these patients. So if the patient has high risk, it is more than 20, the risk is more than 20 to develop 10 years cardiac event, or between 10 to 20, or between 5 to 10. After we confirm the diagnosis of diabetes, so we need to start to treat the diabetic patient who has cardiovascular disease. This is very interesting slide, just published 2 or 3 months ago, and it shows that strict glycemic control can lead to great reduction in non-fatal myocardial infarction and composite of microvascular outcome. And this is very interesting. Paper was published by Sattar last year, and shows that we are going to coronary artery disease with age. But the curve is increased when we have prediabetes, and if you have diabetes, the curve is increased for high incidence of coronary artery disease in this patient. So the guidelines is very clear that in patient who has diabetes, you should give a treatment for hyperglycemia with a drug that have proven efficacy and safety for the patient. Even the patient is on anti-diabetes such as this sulfonylurea, you should switch this drug to a drug that proven efficacy and safety. What is this drug? Actually, this is a long list, but I will skip some of them. So the first line is GLP-1 inhibitors and SGLT2 inhibitors. So they are the first line, independent of glycemic control. What I mean, if the patient already euglycemic, you should start this medication in spite of glycemic control. And if the patient has diabetes with heart failure, in which range of heart failure, you should start with SGLT2. And as you heard from the previous lecture, that SGLT2 is the treatment of all cardiac problems, including heart failure and CKD and extra. If you need additional treatment, you should think about the drug that's not affecting the heart, and including sitagliptin, linagliptin, metformin, insulin if you need it, and try to avoid drug that has no safety in cardiac patient, including pioglitazone and 6-glitazone, because there is, from randomized trial, it shows that can lead to heart failure hospitalization. Better to be avoided. So what about lipid management? And I think there is some speakers that discussed this issue, but I will try to summarize it. The point here, the lower the LDL you get, the better the survival will be. So when you decrease the LDL, you will have a good survival. And MI rates can be halved by aggressive LDL lowering. This is the recent guidelines that was published just 1 month and released in AC Cardiology, and they classify the patient into mild, moderate, high, very high, and extreme risk, which is the new classification. Extreme risk, that means the patient who has atherosclerotic coronary artery disease, but they have recurrent event. So in this situation, you need to have LDL to be at least less than 40. And patient who has very high risk, LDL should be less than 55 or equal 55. If high risk, 70, and if moderate risk, 100, and extra, you can decide. Which treatment you give in this patient? Almost always statin is the first line in the treatment of diabetes and the hyperlipidemia. And you can see that there is no therapeutic approach had more profound effect in the prevention of cardiovascular disease in diabetic patients except statin. So we'll start with the statin. If tolerated, if not tolerated, or reach to maximum dose and you didn't reach the target, you should add the second line, which is azithromycin. And if not, you can start with PCSK9 or bempedoic acid, which is now in the new guidelines is class 1 indication. If the patient have some residual hypertriglyceridemia, so you should go to icosapentaine, which is a class 1 indication, a class 2A indicated in patients with hypertriglyceridemia. But there is a query of fibrate. Fibrate still have the same seat, class 2B, from the old guidelines in 2016, and you can see that it's still class 2B. The reason behind fibrate is not upgraded to class 2 or class 1, that came from the prominent trial. This trial was published in New England Medical Journal, and it shows there is a reduction in hypertriglyceridemia, but the reduction was not significant in comparison to placebo. So fibrate is considered the last line if you don't have icosapentaine. This slide just shows you how much you want, if you want to combine, how much you will decrease the LDL, and I will not go through it for the sake of time. What about hypertension? Hypertension and diabetes has a global pandemic, and hypertension is found in 75% of patients who are diabetes. So we need to be careful in management of hypertension with diabetes. There is many guidelines, American, European guidelines, and many classification, but I will go to this classification, which is easy. They classified hypertension into non-elevated, elevated, and hypertension. So the guidelines is very clear. If the patient has diabetes, you should screen for blood pressure and recurrent measurement of blood pressure for this patient. And when the patient has blood pressure 140/90, you should start medical treatment. Again, ambulatory blood pressure monitoring was recommended, and it should be done in some patients because it can give you the circadian rhythm of blood pressure and dimming blood pressure during sleep. So how to treat this patient with high blood pressure? Make it simple. If the patient more than 65 and he is diabetic, or he has target organ damage or hypertension-mediated organ damage, you should treat this patient directly with antihypertensive. But if the patient has age less than 60, we should have score to diabetes to reassess this patient and to see in which risk he has. Then we start the treatment accordingly. أنا كويس والله. شكرا. لا تخليني أحس إن أنا يابس. أنا يابس من بيتنا. So, how low we should go with the blood pressure? How much we reduce? Actually, the guidelines is very clear. The target blood pressure is 130 in diabetes. You may go lower to less than 120, but less than 120 is not preferred. Because remember, there is some patients who are fragile, patient with old age, more than 85, or patient who develop visceral hypotension, patient who has life expectancy is less than 3 years. It's better not to push him to lower blood pressure in this situation. What about the medication? The medication has not changed in the guidelines from 4 years ago to now, are the same drugs. And you should start with ARNI or ACE inhibitor plus, or ACE inhibitor, or say a calcium channel blocker plus diuretics. If no response, you can increase the dose. If no response, you can make a triple antihypertensive. If the patient has resistant hypertension, you should go to add a new drug, which is spironolactone in the treatment of hypertension. What about antithrombotic? We all know that diabetic is a prothrombotic disease. And this is clear because there is endothelial dysfunction and there is hypercoagulability state and hypofibrinolysis. So we have to treat these people. Very important point we have to know it about aspirin in the primary prevention. This is a huge meta-analysis, and there is many discussion in the clinic. You can face it. I'm sure that all of us, we are asked, can we take this aspirin or not? In diabetic patient, as a primary prevention is a class 2B. That means you may give it because aspirin in this meta-analysis show there is reduction in MACE, but there was no effect on mortality. For aspirin, you should individualize all patients in order to give them aspirin. So this is a busy slide. I will not go through it, but in primary prevention, in diabetes, you can give aspirin as primary prevention, but you should remember the risk and benefits. Sometimes patient who has bleeding or epistaxis or any GIT bleeding, and you want just to do primary prevention, it's better not to give this patient aspirin. Okay. In regard to dual antiplatelets, we all know antiplatelets, aspirin plus minus clopidogrel or ticagrelor. When you give this patient in acute situation, you should combine dual antiplatelets, aspirin plus clopidogrel for 1 year. I will not go to the details because it's not important for endocrinologists. If the patient has atrial fibrillation, we should think about anticoagulant in combination with aspirin or in clopidogrel, preferably clopidogrel. There is many new oral anticoagulation you can in the market. So what about obesity? I think obesity was presented in details with other speakers. But what I want to say that obesity is playing as an important role in developing cardiovascular risk. So it's class 1 indication. That means you should reduce the weight either by exercise or by diet. And there is a promising trial, such as SELECT trial, that GLP-1 are a good drugs to reduce the weight, but it should be considered in patient who has body mass index more than 35. So in summary, this is modern treatment of type 2 diabetes in cardiovascular continuum, including heart failure, left ventricular remodeling, and the extra. And we need just a team discussion in order to help the patient and to give him the best treatment. Looking to see you next year, inshallah, in our symposium. Thank you very much. أجلس ولا